Hello and welcome. I'm Dr. Michelle Josephson. On behalf of CME Outfitters, I'd like to thank you for joining us today for Why Are We Still Talking About the Mycophenolate REMS in 2024? This CME activity is supported by an educational grant from the Mycophenolate REMS Group, a consortium of more than 20 companies who provide branded or generic forms of mycophenolate. CME Outfitters is a jointly accredited provider and develops and certifies continuing education activities for the team, by the team, including our program today. Don't forget to follow us on X with username @CME Outfitters for upcoming CME CE opportunities, healthcare news, and more. We'll also be responding to relevant posts received throughout this session. Again, I'm Michelle Josephson. I'm a transplant nephrologist at University of Chicago, professor of medicine and surgery, and director of education at our Transplant Institute. I'm very proud to be joined by a superb panel who I'll ask to introduce themselves, starting with Dr. Moritz. Dr. Moritz.
Michael Moritz, the principal investigator of the Transplant Pregnancy Registry International, headquartered at Gift of Life Institute in Philadelphia. I'm also the medical director for the Gift of Life Donor Program, the organ procurement organization for our region, which is also headquartered in Philly. And I'm recently retired after 37 years as an active liver, kidney, and pancreas transplant surgeon. I am not taking call anymore.
Hi, and I'm Lisa Cassia. I'm the Senior Nurse Research Coordinator for the Transplant Pregnancy Registry International, and I've been in the transplant field for over 30 years.
Thank you both. Now to get started, I'm going to provide a brief introduction and history of the mycophenolate risk evaluation and mitigation strategy, or MREMS. Mycophenolate was approved in the last millennium, which I remember well, and evidence of teratogenicity emerged in the early 2000s. Case series showed characteristic recurrent patterns of malformations, and this resulted in boxed warning in 2007 and the requirements for a medication guide in 2008. Evidence of mycophenolate teratogenicity was paralleled by a greater regulatory effort to improve drug safety, represented by the FDA Amendment Act, or EFTA. This introduced the concept of REMS programs as a way to ensure benefits outweigh risks. This led to the mycophenolate REMS in 2012. Of note, since its inception, the MREMS has been a shared system, or SSMREMS, used by all manufacturers and marketers of mycophenolate products. In 2023, a parallel system, or PSMREMS, was introduced as part of the FDA's waiver process to protect patents. It is largely identical to the information in the SSMREMS. Either system can be used by clinicians and patients. Many references on today's slides will include the websites for both the SS mycophenolate REMS and the PS mycophenolate REMS. So the goals of the mycophenolate REMS is to educate providers as well as educate patients. For providers, is to educate healthcare about increased risk of first trimester pregnancy loss and congenital malformations with exposure to mycophenolate, counseling patients of reproductive potential on preventing pregnancies when taking mycophenolate, reporting pregnancies to the Mycophenolate Pregnancy Registry, and reporting pregnancies to the Transplant Pregnancy Registry International, TPRA, formerly the National Transplantation Pregnancy Registry, or NTPR, TPR. And we are joined here today by Lisa and Michael, both of whom work closely with TPRI and also educates patients on increased risks of miscarriage and birth defects, importance of pregnancy prevention and planning when taking mycophenolate, participating in the Mycophenolate Pregnancy Registry, and participating in the TPRI. So you may be wondering, why are we still talking about MREMS? Well, there's several reasons. One is that MREMS has been suboptimal at best in preventing prenatal exposure, and we'll talk about that a little bit more. Also, new and evolving abortion laws leave limited options when accidental prenatal exposure occurs. For example, there might be absolute or 6-week abortion ban restrictions, opportunities, and this restricts opportunity to consider pregnancy termination. The potential for malformation is generally not recognized as an exception to strict abortion laws, and that's why this is so very important and relevant. So now I'm going to turn things over to Dr. Moritz, who will talk about mycophenolate in clinical perspective. This section will address the first of 3 learning objectives, namely to evaluate embryo-fetal toxicity and pregnancy risks associated with the use of mycophenolate. So let me turn it over now to Dr. Moritz.
Thank you, Dr. Josephson. Let's start with sort of a pre-question, since we haven't learned anything yet. But it gets right to the heart of the matter. What percentage of infants born to an individual exposed to mycophenolate during the first trimester of pregnancy will be born with congenital abnormalities? Is it 10 to 15%, in the range of 20 to 25%, in the range of 45 to 50%, more than 50%, or I'm not sure? Please go ahead and register your answer now. And the correct answer is 20 to 25% of infants with a first trimester mycophenolate exposure will have major malformations. And at least a quarter of you got that correct. Now let's move on to some brief history about mycophenolate. Mycophenolate was the first antibiotic purified from any source, discovered by an Italian named Dr. Gozio. And it's an acidic phenol from a fungus. And you should all remember that fungal products like this include cyclosporin, tacrolimus, penicillin. So fungi produce a variety of chemicals with funky properties. It's been rediscovered as an antibiotic, antifungal, antiviral, antitumor. It was used for a lot. It was attempted to be used for a lot of things until the 1960s, when its immunosuppressive properties were first identified. There are 2 forms of mycophenolate available: MMF, mycophenolate mofetil, and MPA, mycophenolic acid, enteric-coated. MMF is available both orally and intravenously, and the FDA label indications include prevention of organ rejection and allogeneic kidney, liver, and heart transplants in combination with other immunosuppressants. The enteric-coated or delayed-release mycophenolic acid, oral tablets only, and the same FDA-labeled indications. As an immunosuppressant, it's now being used in other off-label indications. You'll notice that neither lung nor kidney pancreas nor small bowel nor VCA transplants are part of the label. Likewise, bone marrow transplant is not a label indication, and a variety of autoimmune conditions, including rheumatoid arthritis, inflammatory bowel disease, skin disorders, including psoriasis, and other classic autoimmune phenomena like lupus and various vasculitides, also have had some success when treated with mycophenolate. So how is it an immunosuppressant? So this pathway that's shown vertically is the de novo purine synthesis pathway. And purines is what DNA is made of. And so the ability to inhibit this pathway will inhibit DNA synthesis and thereby inhibit cellular proliferation. So this de novo purine synthetic pathway is, relatively speaking, something that lymphocytes are more dependent on than other cell types. Hence, the effect of the drug is felt most strongly by lymphocytes, and its side effects are attributable to similar but not as potent effects on other non-lymphocyte cells. The teratogenicity means the ability to cause birth defects. Mycophenolate was first described in 2001 in a child born with hypoplastic nails and shortened fingers to a mom who'd been exposed to mycophenolate during the pregnancy. Other subsequent single reports followed. And a pattern was noted, and that's what's called an embryopathy. Not random birth defects, but a pattern of birth defects that's associated with fetal exposure to mycophenolate. The most prevalent of the malformations are ear malformations, including microtia, small ears, anotia, absence of the external ear, and they may be associated with inner ear problems as well, including atresia of the auditory canal and deafness. Also, orofacial malformations, including cleft lip and palate, congenital heart defects, tracheoesophageal malformations, and dysmorphia of the face and distal limb anomalies, like that first case where the fingers were affected. Dysmorphia, in a pejorative way, is often referred to as funny-looking kid, FLK, in the genetics world. So the risk is embryo-fetal because there are actually two things. One is the risk of birth defects, and the other is fetotoxicity, or spontaneous miscarriages. Now, spontaneous miscarriages either can be because a drug is toxic to the fetus, or they can be miscarriages due to severe malformations that are not compatible with life, and typically you don't know. In 2006, we reported, when it was still called the National Transplant Pregnancy Registry, on 24 female patients, 33 mycophenolate-exposed pregnancies, almost half, 45%, had spontaneous miscarriages. And in the 18 live-born children, 4, which is 22%, had structural malformations. Post-marketing data from Roche, which was the manufacturer of Cellcept, and this was only available as a branded medication at that time, they had accumulated 77 exposures, of which 33% had spontaneous abortions and 18% had major malformations. This led to the 2007 boxed warning on the product insert, which I am not going to read, except for the blue part. Use during pregnancies associated with increased risks of first trimester pregnancy loss and congenital malformations. We also, at the NTPR, in our annual report, noted that pregnancies conceived on mycophenolate, and we compared them to women who had conceived when mycophenolate had been discontinued at least 6 weeks prior to conception. Those women had a miscarriage rate of 22%, In contrast, the women who were still taking mycophenolate while pregnant had a miscarriage rate of 48%. Pre-pregnancy counseling and adequate contraception are critical if young women who need to take mycophenolate. Notice the question mark in the title. Are there safer alternatives to mycophenolate in the setting of organ transplantation, in particular, where women and all patients are typically on combination therapy of multiple drugs? In an optimal setting, a woman plans a pregnancy and her care providers have the opportunity to consider, is it reasonable for her to switch from mycophenolate to an alternative? That gives the opportunity to switch and ensure that nothing adverse happens to the allograft prior to the pregnancy. Classically, azathioprine has been the drug that most women have been switched to. Azathioprine dates back to the early 1960s. And so the experience prior to calcineurin inhibitors was actually relatively extensive, although the drug was used at much higher doses when there were no calcineurin inhibitors. Regardless, it has some capability of causing teratogenicity in animals, but not in humans. It's not been noted as a human teratogen. A retrospective cohort study which compared pregnancies exposed to mycophenolate to those in azathioprine during the first trimester. Again, almost 50% pregnancy loss with mycophenolate exposure and 24% with azathioprine. The other alternatives would include the mTOR inhibitors, classically sirolimus. They likewise do have teratogenicity in animal models. Safety data to fetal exposure to these drugs is relatively sparse. We're talking a couple dozen cases that have been reported. And the problem is that the mTOR inhibitors are inhibitors of cellular proliferation, which seems a problem when you talk about a fetus which has rapid cellular proliferation. KDIGO guidelines currently advise against mTOR use in pregnancy. And that is the current state of affairs with mycophenolate and pregnancy.
Thank you, Dr. Moritz. Now let's look at how to counsel patients of reproductive potential regarding mycophenolate use. So we're going to go on to our learning objective number 2, and that is to counsel patients of reproductive potential on pregnancy prevention and or planning during mycophenolate treatment. To open this part up, what I'd like to do is turn now to our second of 3 ARS questions and ask the audience, what percentage of pregnancies are unplanned? Is it A, 18%, B, 25%, C, 40%, D, 54%, or E, you're really not sure. So go ahead and register your answer while you hear the music playing now. Okay, well, let's see how everyone did. So the correct answer is C, 40%, and a third of our audience did get that correct. And so we're gonna, we'll come back to this question again, but it's just important to know that it is really that high. So with that said, we're gonna now move on to prenatal exposure to teratogenic drugs. So turns out that this prenatal exposure is actually quite common. And in a paper that was done by Sarayani, prenatal exposure to teratogenic medications in the US occurs way too often. And although EFTA has resulted in increased regulatory efforts, turns out that only 10 of more than 140 medications with known teratogenicity risk currently have a REMS. And for the remainder, we have to rely on the warnings in the package inserts. Now, Sariano did some other very interesting studies, which we're going to turn to now. And so it turns out that the delayed introduction of the mycophenolate REMS several years after the risk of teratogenicity was well established provided us with an opportunity to evaluate the effectiveness of the REMS. And so that is really what enabled Yanni to do the study. What Sariani did was compare the risk of prenatal exposure among persons of childbearing potential who used mycophenolate during the medication guide period versus the period after 2012 when REMS was introduced. So let's go ahead and look at it here. And what you can see is that you can see the introduction of the medication guide that starts in the blue period and then the REMS period as depicted in the red in the slide. And in order to get at this information, Sariani used a market scan database that had information between 2008, 2015. And this was a national sample of privately insured patients. And the eligibility for those included were persons of reproductive potential between age 15 and 44. And these individuals had filled at least one prescription for oral MPA. And what they did is they looked at the MPA treatment period, and they looked at an index date of the dispensing day of the first MPA prescription in each episode. And they looked back over 6 months. So they had two different analyses. And in the first analysis, what they did is they looked at whether there was a pregnancy that was ongoing at the time that treatment was initiated. And again, they looked at this in the two periods, the blue as indicated by the medication guide, the red as indicated by REMS. And they said, were individuals who were pregnant given a prescription for MPA? And then in analysis number two, what they did was they looked at whether or not either the medication guide as depicted in blue or the REMS period as depicted in red was better at preventing pregnancy or conception during treatment. So let's take a look at what they found on the next slide. And so what you can see here is that for analysis number one, when they looked to see what was the portion of pregnant individuals who had mycophenolate treatment initiated, they found that actually it really came down during the REMS period. So the REMS period seemed to be much better at preventing providers or those writing prescriptions from writing prescriptions for pregnant women. On the other hand, when they looked at the rate of conception during mycophenolate treatment, there was really not much difference between the medication guide period and the REMS period. Now, you may be saying, well, why did this happen? Unfortunately, we really don't have specific information about why this happened for the mycophenolate REMS, but we do have, there are other REMS, and we have data from the time period for which results of the isotretinoin pregnancy registry. And you can see that in the slide. And what you'll notice is that there are several reasons why, at least for this drug, there were pregnancies that occurred. One of the big reasons was there's contraception failure. Another was that people didn't use two birth control methods. And another was unsuccessful abstinence. So then the big question is, what can we do? So let's move on to that. Think about that. So remember, 40% of pregnancies are unplanned. And there's also other things to be aware of. implementing MREMs in clinical practice can be very difficult. For any clinician in the audience, you understand the time constraints that we're under. There's also the issue of patient perceptions. There's a level of comfort that that providers and may feel about these kind of discussions, and we're going to talk a little bit more about that. And then it's also important to consider that there may be issues that need to be addressed with respect to cultural, language, and health literacy barriers or specificities that need to be considered. And so one needs to sort of come up with strategies to really reduce these kind of poor outcomes, and to think about how we can counsel patients so they do use adequate contraception, to think about performing pregnancy screening, to think about reporting pregnancies to the Mycophenolate pregnancy registry. We'll talk more about that as well. To consider cultural and language and health literacy barriers, and also other social determinants of health when counseling patients. So let's now turn our attention to the issue of counseling and recognize that we really need to prepare for this conversation, that we need to think about addressing reproductive goals prior to the start of mycophenolate, that we need to think about creating an open, supportive, and non-judgmental environment. That we need to think about increasing your knowledge and self-efficacy in providing contraceptive counseling. And we need to consider incorporating MREMs into documentation and the clinic workflow. Now, before we had this presentation, actually, Lisa, Michael, and I had an opportunity to talk a little bit about this issue of counseling. And Michael talked a bit about how difficult it is in all settings, but how particularly difficult it is to talk to adolescents about this issue, particularly when they have very involved parents. So I'm going to, for a few moments, turn the floor over to Michael for him to share his experience in this arena. So Michael, if you could share a couple of thoughts on this with the audience, that would be great.
I had the privilege of being a transplant surgeon. And in that role was often the most trusted provider that the patient would see. COVID sort of re-emphasized that patients would say that was the only environment in the healthcare world where the office where they would feel safe, where they knew everyone had been vaccinated and everyone stuck to the masking guidelines. And they've always taken the transplant office as some place of trust because no one prescribes medications they shouldn't get there, et cetera. When you're talking with younger people, particularly young women, about this whole pregnancy thing and mycophenolate, so you sort of have to have a minimum. You have to have a conversation with the patient. Period. You have to have a conversation with the patient alone. So those with clingy parents, you get an excuse. You get someone to call them out into the waiting room. You must have a conversation with whoever they bring to the office, then have a conversation alone. If they happen to have a significant other, that's great too. But you have to start at some point with a conversation with the young woman alone. She may not be honest with other people in her life about her plans for pregnancy. In fact, there's no reason to think she would be honest with parents or even with a significant other. But she will be honest with a trusted provider. That's the best we can do.
Thank you. I think those are really important points. So let's then think about some of the issue about contraceptive counseling. So who do we counsel? Well, we want to counsel patients of reproductive potential, and that would include anyone from puberty all the way through menopause. And I sometimes think people miss that group. I mean, the menopausal group to counsel on, sort of maybe not realizing that they are potentially at reproductive age. We want to exclude anyone who's had a hysterectomy, oophorectomy, or premature menopause. And I meant to say really pre-menopause when we want to talk within that reproductive period. How often should we counsel? Well, we should certainly start prior to initiation of mycophenolate. And then it's important to bring it up at every follow-up visit. That will also make it much more easy to discuss and also emphasize the importance. When to use contraception, certainly during treatment, as well as at least 6 weeks after ending medication. And what about pregnancy screening? How often should we do it? Well, we should start immediately prior to the start of treatment, 8 to 10 days after starting treatment, and then at every follow-up visit, as well as 6 weeks after discontinuation. So what about birth control? What are our options? Well, it turns out that we do have several options. Now, if someone simply wants to have one method, then aside from sterilization with either tubal ligation or vasectomy, the only possible option is really an IUD. But if someone doesn't want either sterilization or an IUD, then you have to use 2 methods. And you can use sort of a menu of potential methods, as you can see here. And you can use a method from what's listed in the list of B, or you can use B in either C1 or C2. So you can sort of put all of, mix and match a little bit if you are going to do 2 methods, but you do need to use 2 methods. Now, the other way that you can help a patient prevent pregnancy is to inform them and provide them with emergency contraception. So let's take a look at those options. And you can see that there are several options. There's Plan B, and there's also Ella, and there's a copper IUD. But they do need to be instituted within days, 3 to 5 days. If you're doing Plan B, it has to be 3 days. The other methods you can do within 5 days. And the good news is that they at least Plan B is over the counter, but they do need Ella does need a prescription, and certainly a copper IUD. You're going to need to have someone to insert it. So, but those are very important good options. Now, we spoke a little bit earlier about the fact that you may not feel